Pharmacy Foundations, CYP450 drug interaction. Now imagine here we have the 3A4 enzyme and we have all these cardiovascular drugs, we have anticoagulants. Imagine what could happen if we give any of the senior cups, which would be inducers. Inducers decrease the level of the substrate, so we're going to have less of an effect. That means our drug is going to be ineffective. So in the case of, let's just say, rivaroxaban with the inducer carbamazepine, the carbamazepine is the inducer. It's going to decrease levels of rivaroxaban, leading to inefficacy and potential for clot. So it's dangerous. So let's pretend we have an opiate. How about oxycodone as a substrate? And then we have an inhibitor. Let's say we have a macrolide, clarithromycin. We take clarithromycin with our oxycodone, and since clarithromycin is an inhibitor, it will heighten the levels of the substrate, leading to potential toxicity, respiratory depression, and even death. These are some pretty big drug interactions here. Now we have also estrogen. Let's just take estrogen. Maybe somebody is on their oral contraceptive, they're taking estrogen, and then the doctor prescribes carbamazepine. I keep using that. So carbamazepine is the inducer. It decreases the level of substrate in the blood, so the estrogen levels will decrease. The scary part about that is that we're going to have inefficacy of the birth control, and what's scariest is that carbamazepine is teratogenic. So giving carbamazepine and making the estrogen ineffective is going to be highly problematic. Now remember how we said that carbamazepine is an autoinducer, that it is an inducer, but it's also a substrate? Let's look at the drug interaction. Let's say somebody was started out on carbamazepine. They were doing well. You know, we have to monitor levels of carbamazepine. They've been okay. And they just start having more, and the doctor decides to put them on another drug. Let's just pick phenytoin. Phenytoin is an inducer. Carbamazepine is an inducer, but carbamazepine is also a substrate. What could happen once we add on phenytoin? Carbamazepine was balanced out. We were doing just fine on it to begin with. If you add phenytoin, phenytoin will not act on another inducer. It's going to act on the substrate. So that combination could actually decrease the level of the carbamazepine, making it less effective, even though we're adding on a second drug. Moving on from 3A4, now let's go to enzyme 1A2. The main substrate is theophylline. The primary inducer that we hear the most about on the test would be smoking, so smoking could decrease levels of theophylline. It's an inducer, decrease levels. The inhibitors are ciprofloxacin and fluvoxamine are the main ones. Cipro is an inhibitor. It heightens the level of theophylline. Next, 2C9. S-warfarin, that is going to be our strong enantiomer of warfarin as a substrate. So the warfarin level could either be ineffective or toxic. It could lead to clotting or bleed, so we must be very attentive to inducers and inhibitors. So inducers decrease the level of warfarin. What would happen if somebody decided to start taking St. John's wort with warfarin? That's right, St. John's wort is an inducer. It decreases the level of warfarin. As for inhibitors, my mnemonic, BAAM, is the inhibitors that interact with warfarin. Bactrim, azoles, amiodarone, and metronidazole. Those two A's were already part of G-Pacman. We're just adding on a couple antibiotics. So warfarin with the inhibitors will increase the risk of bleed, increase INR, because inhibitors heighten the level of the substrate. BAAM, picture a gun, blood everywhere, so it's going to increase the risk of bleed. Now the next enzyme for us to know is 2C19, and the main drug will be clopidogrel. Remember that, look at that number under the enzyme, 2C19. The C1 looks like Cl for clopidogrel. Well, remember that clopidogrel is a prodrug. We do have our regular inducers. Most of them are the same drugs as senior cops, but inhibitors change. Omeprazole and S-omeprazole are the main inhibitors for the 2C19 enzyme. And what will happen when we give omeprazole and clopidogrel together? Well, ordinarily, an enzyme block this enzyme and inhibit the metabolism of the active substrate. So we would have more and more active drug. Picture it going to the left, that we have more drug on the left-hand side. But in this inactive substrate being metabolized, so we will have the opposite effect. When we have an inhibitor blocking that enzyme, there is going to be more drug going to the left-hand side, and in this case, it's going to be more clopidogrel, the inactive substrate, and less of the active metabolite on the right. It is important for us to know about the PPIs and the drug interactions they have at the 2C19 enzyme with clopidogrel or Plavix, because those PPIs, it's important for pharmacists to be able to communicate the drug interaction to their Plavix. Last, we have the 2D6 enzyme. I think of mostly pain drugs and psych drugs, like antidepressants and antipsychotics, for this enzyme as substrates. There are not really inducers. Inducers typically decrease the level of the substrate. Inhibitors heighten. Fluoxetine and paroxetine are inhibitors, so they will most often heighten the level of the substrate. But what happens when we have a prodrug? Tamoxifen, codeine, and so if we give an inhibitor like fluoxetine, paroxetine, or amiodarone along with them, the metabolism will be inhibited, blocking the conversion to the active drug. So we'll have inefficacy with any of those prodrugs when combined with the inhibitor. One example that's significant here would be tamoxifen. We remember we use that in breast cancer. Often people taking tamoxifen because it's reducing the estrogen levels, so it's prematurely putting somebody into menopause. So what goes along with menopause? We get hot flashes, vasomotor symptoms, and paroxetine we do use for postmenopausal women with but in this case, we cannot use the combination tamoxifen and paroxetine to prevent hot flashes because of the drug interaction. Paroxetine would make tamoxifen ineffective. Remember, this is a prodrug, so the inhibitors ordinarily would heighten the level of the substrate, but in this case, it's going to reduce, so making tamoxifen ineffective. Or could return. Now would be a good time to discuss genetics of the 2D6 enzyme. Some people are ultra-rapid metabolizers. That would make codeine, the prodrug, metabolize quicker into morphine, the active component, and that could cause toxicity. So today, We covered CYP450 metabolism, we learned substrates, we learned inducers and inhibitors, we learned about prodrugs. Stay tuned for other types of drug interactions. Bye!